So thanks very much. Yeah, this is a sort of related topic on another complication associated with paediatric uveitis. So as you know, the cataract in paediatric uveitis occurs due to the inflammation itself and also the use of topical and oral steroids, and it can come on very quickly as a result of those things. The incidence of cataract in uveitis has been reduced for several reasons. One is because we're now screening children at risk of uveitis, so we're picking up the uveitis before it causes the complications, hopefully, and also because of the better use of immunosuppressive agents, we're treating uveitis earlier, hopefully before it causes cataracts. But sometimes we have a child who presents with uveitis before we've even made presents with a cataract before we've made a diagnosis. This cataract here was a girl who was noticed to have divergent squint, was found to have a white cataract in one eye and chronic uveitis, and then went on to have the diagnosis of JIA made after that. So as we've already heard, anybody has a cataract in association with uveitis, if they're not already on systemic treatment such as methotrexate or something similar, needs to have treatment. Avoid excess steroid use. 1 or 2 drops a day is probably okay, but any more is not. Oral steroids should not be used in the long term for the reasons we've discussed. And any child with a cataract, monitor their intraocular pressure very closely. Just a point, check, if you have a child with cataract, before you consider surgery, check refractive error and amblyopia, because sometimes those things are contributing to the visual loss. It's not unusual for a child with a uveitic cataract to become myopic, so refractive error can account for some of the visual loss. For that reason, you can therefore avoid unnecessary surgery. I've had a few children who've been referred with for cataract surgery when they've got uveitis and they've had extensive posterior synechia and a fibrillary membrane. And actually, when we corrected their myopic refractive error and gave them some time on methotrexate, the vision came up. So they don't need necessarily to have surgery in that situation. I think you have to make a judgment call. And in an ideal world, you want to maximize the control of the uveitis before you undertake any surgery anyway, so leave them a few months. Obviously, if they've got bilateral white cataracts, you're not going to be able to do that. You don't want to leave a child with no vision. But if you can wait a few months, see what the effect of the methotrexate is and the amblyopia treatment or the refractive glasses, and you may not need to operate. If you are going to operate, you need to be aware of all the issues around doing pediatric cataract surgery. As I said before, you need ideally the eye needs to be quiet before the surgery. You can optimize uveitis control around the time of the surgery by giving them, I give IV methylprednisolone 2 doses. I admit the child under the care of the pediatric rheumatologist for the 2 days before the surgery, and then each of the preceding day they have a dose of IV methylprednisolone. Other people give a course of oral steroids before and afterwards. If the child's got macular edema or hypotony, then you can use intravitreal steroids at the time of the surgery, and I always give orbital floor steroid at the end of the surgery, and obviously hourly topical Pred Forte for the week or so after the surgery, gradually tapering down. The surgical technique is important, and I'll talk a little bit about that shortly. And my rule of thumb is basically avoid intraocular lens insertion in children with complex uveitis, or if they've got JIA-associated uveitis, or if they have active uveitis requiring immunosuppression. So why would we not put an intraocular lens in? Well, of course you can, but if you do so, you need to have a conversation with the family to say that these are the things you risk. You risk the need for ongoing immunosuppression. You may never be able to get that eye quiet if they've got an intraocular lens in. You risk them forming posterior synechia and membrane formation, capsular opacity. The need for further surgery for that is increased, and long-term glaucoma risk. So if you're going to put an intraocular lens in, be prepared to reoperate. Be prepared possibly for them to be on, to have the need to remove the intraocular lens, and be prepared for the child to be on long-term immunosuppression. And also just to say that I've had lots of children that I've left aphakic, particularly those with JIA-associated uveitis, and they've had very good visual results, and the eyes are quiet, eventually coming off immunosuppression. This girl at the bottom with very good visual outcomes. So my rule of thumb is no most of the time. Obviously, there are exceptions to that. I would say a definite no for JIA-associated uveitis, and those are the children usually have band keratopathy, posterior synechia, they can become hypotenuse, and putting a lens in would be technically very challenging anyway in these cases. I'll talk a little bit more about that. No, if the child is requiring ongoing systemic immunosuppression, which is most of the young children with uveitis. know if extensive posterior Seineke band keratopathy and hypotony for obvious reasons. If the uveitis is quiescent and burnt out, okay, you can consider it. Yes, possibly if the cataract is mostly due to the steroid rather than the inflammation themselves. So those are the eyes that don't have band keratopathy, normal intraocular pressure, no posterior Seineke with a posterior subcapsular cataract. And there are some infective causes of uveitis. Obviously, if a child's had a flare-up of toxoplasmosis and had treatment for that and has got a secondary cataract following that, probably due to the steroid use, yes. There are some rare occasions, but if you're not sure, leave them aphakic, and I think you'll sleep better at night. So when I do the surgery, I use a bimanual lensectomy technique with a vitrectomy cutter. I've moved to a 23 gauge vitrectomy, which probably most people who are doing pediatric cataracts have. You need to divide the posterior Seineke, and I also do an anterior posterior capsulorhexis with a wide excision of the capsule and anterior vitrectomy at the time, and I do a peripheral iridotomy with a cutter at the end and put orbital fluoropyrimidine in. Oops, sorry, hold on, I'm going back too quick now. So I've got some videos if it'll work. So yeah, this is a video of, obviously speeded up, of a child with a uveitis-associated cataract. So just a couple of points. You can see that the posterior Seineke in these cataracts is not just the border of the pupil, it's actually spread across the whole lens. And so you need to do a very wide sweep to divide those posterior Seineke, not just at the pupil margin. The iris is very, very floppy in these patients. So if you decided to put an intraocular lens, for example, you would very likely have a high risk of iris prolapse. And when I've seen other people try and do this, often the child's lost a lot of iris in the process. So it's another reason for just doing the bimanual technique with very small incisions. I try not to use iris hooks, but sometimes it is necessary. If you can avoid it, obviously it reduces the inflammation post-operatively. So if you can avoid iris hooks, sometimes just a gentle iris stretch is sufficient. I think, yeah, so in this child I didn't use iris hooks. The other thing to mention is those of you that have done cataract surgery in children with uveitis, sometimes the lens is very sort of gluey and it doesn't want to come out, or doesn't want to be aspirated as readily as a child who doesn't have uveitis, and sometimes it just takes quite a while. And you can see often the anterior chamber is quite shallow and a very, very floppy iris. So I enlarge my anterior and posterior capsulotomy to just leave a rim of capsule, basically, again, just to reduce the inflammatory effect of any residual lens epithelial cells, and do an anterior vitrectomy. And then at the end, I do a PI with the cutter, just to avoid pupil block glaucoma afterwards. There you go. So that's the end of my presentation. If anyone else got any comments or thoughts or experiences to share, thank you.
Thank you, Jane. Well done surgery. Just if in cases you have a unilateral case and it's a young child and you have well-controlled uveitis and of course sequelae like band keratopathy with a cataract, would you like to put in, and would you be putting emphasis in putting the IOL in the bag? What are your, what would you consider?
I'd still be very cautious about that. I know obviously you have the issues with amblyopia if you're not able to correct the refractive error, leaving them aphakic, but I'd probably use a contact lens if I could. I think that you'll have a significant risk of complications and risk exacerbating the uveitis. So, I mean, it would very much depend on the context. But the other thing to remember is that children who have, especially if it's a young child who has idiopathic uveitis, for example, you know, I sometimes wonder, have they got an unmasked rheumatological disease? You know, it's a spectrum, isn't it? So they might not have JIA, but if it's a JIA-like uveitis, then I'd be concerned that the prognosis for the control of the uveitis was not good. So I'd be very cautious still. I think my default option is generally don't put an intraocular lens in. I would use a contact lens if the eyes was quiet and they weren't needing a lot of topical steroid.
Any from the panel? Anything from the audience? Yes.
I tend to try and avoid that because I think I know, there's been case series of success in pediatric uveitis with short follow-up, but when I've spoken to people who have written those case series, in the long term, children always get cataracts and glaucoma, or very frequently do. So again, it depends on the context. If the child's already aphakic, I'm more inclined to do it. If the child's having cataract surgery and they've got macular edema, then I will do. But I think if the child's getting to the stage where they need intraocular steroid, then you need to maximise their systemic immunosuppression as a priority. It can be a helpful adjunct, but it does have its issues. Yes. So only if they're hypotenuse or have macular edema. I don't use intraocular steroid, I use orbital floor otherwise.
To the eye at the end of surgery has been one of the revolutionary things I've done in pediatric cataract surgery. And it's an amazing medication inside the eye. It works quick initially, although, like you say, you need longer term, maybe depamedrone on the orbital floor as well for a longer term effect.
Yes, yeah. Great.
Any thoughts of putting an Ozurdex implant, especially once you're, of course, getting rid of the cataract?
Well, not immediately, like Jane, I wouldn't do it. But obviously, if they continue to have severe inflammation, Ozurdex works really well. It lasts for about 2 months. It's easy to perform, and I've done this in many of the cases with uveitis, with good outcomes.
But I would only do that if you've tried everything in the way of immunosuppression, and I have done it when I've tried all other options and you're running out of options, but it's not the first thing you do.
Yeah, of course, we had cases after following few months, then of course we had good results over the last 2 years with the Ozurdex. Especially when the compliance is an issue. There's one question from the audience, the last one.
They will get cataracts and glaucoma though, probably. Mm-hmm.
The contact lens, for how long you use it? I mean, you just use the contact lens for the patient aphakic for a long time?
As long as they wish to, yeah. So if they wish to for refractive correction, then some patients are very happy in contact lenses, others prefer glasses. I showed a picture of a child who's very happy in her aphakic glasses, and cosmetically they look fine, has excellent 0.0 vision. Other children may prefer contact lenses, and as long as they are not using too frequent drops, which obviously you're not aiming for them to be anyway, then they can have a couple of drops of steroid if necessary around the contact lenses,
But we have a difficulty, for example, to teach a parent to put the contact lens, and
sure,
this is like it needs a long time. I mean, we use usually we use the glasses. I mean, just for these patients.
Yeah, obviously.